Good morning. Good morning, everybody. We have a great presentation today, and I think there's a lot of people here doing multiple sclerosis or some sort of subtyping. And since we have kind of a smaller group because it's pre-Christmas, I've asked Arman, who will introduce in a second, to maybe keep it informal if people want it to be, so there's more discussions. It's my pleasure to introduce Arman Eshaghi. He is visiting us from University College London from England. Arman has a very, distinguished portfolio in the sense that he has his MD degree from Tehran, and then he went on to do his PhD at University College London, and now he's a research associate at the University College London. He is working on a very interesting and exciting project in the multiple sclerosis world, which is the IPMSA project, which is kind of an international effort to collect all the images and data related to multiple sclerosis from industry and academia, to pull it together and then find some sort of signature for progressive multiple sclerosis using artificial intelligence and machine learning. So Arman's specialty is combining clinical neurology with computational neurology. He's done a wonderful job, and as you can see from his bio, from his abstract that we sent out, he's gathered a huge amount of scans to then do subtyping in multiple sclerosis. Arman is collaborating with Douglas Arnold at the Neurological Institute, who's heading the IPMSA project, and he's also working with the team at UCL in multiple sclerosis and computational neuroscience, especially Professors Olga Ciccarelli and Declan Chard. So on that note, I also wanted to mention that Arman has multiple scholarships. He has been awarded the Young Investigator of the Year from the European Committee for Treatment and Research in Multiple Sclerosis, the Jacqueline Desprez Grant, as well as the Ektrams Magnus Fellowship from the IPMSA, and the Multiple Sclerosis International Federation Ian McDonald Fellowships. It's a long list. So really excited to welcome you here and looking forward to your talk.
Thank you, Arman. Thank you for the invitation. I feel like to be at home because many people are doing subtyping and work in MS. So what I'm going to present to you is a work, Arman mentioned we have gathered a large data set, but actually the most of the work in terms of getting the data from pharma has been done here at Sridhar's and Doug's lab, and also at NeuroRx. In Montreal, what we have done in UCL is to use this data and to look at how we could use data-driven methods that I'm going to show you to subtype patients. So MS or multiple sclerosis, like any other neurodegenerative disease, I just need to apologize in advance to Sridhar, who has listened to me. I think this is the fourth time this poor guy is listening to me giving this presentation. Anyway, thank you for bearing with me. So MS is a very heterogeneous disease, like as you know, like Alzheimer's disease or any other neurodegenerative disease. So the way we subtype patients at the moment, mostly for communication purposes, is to look at the clinical behavior on how patients evolve over time. So we know, for example, we have clinically isolated syndrome, relapsing remitting MS, RMS, and secondary progressive MS patients who later on develop a progressive course starting from attacks and then going on to progress, or patients who progress from the get-go, from the beginning, who we call primary progressive MS. But we also know that based on many pathological studies and also MRI studies, these different phenotypes are actually more similar to each other than being actually different. And after many years, even after 2 decades, we haven't yet found any biomarker to be able to distinguish them other than having a disease duration that is longer in secondary progressive MS. So our hypothesis is that using data, using MRI, we can try to find patterns in subgroups of patients who follow similar patterns over time. And the idea here is that the MRI is closer to the pathology of the disease compared to, for example, clinical behavior. And in a way, it's a bottom-up subtyping as opposed to a top-down subtyping using, if you have the clinical behavior on top and on the bottom you have data. So we are going from bottom up to try to subtype patients. So again, the aim would be to use a method that we have already developed at UCL. I'm going to show you later what this method is. It's a model-based machine learning method. So these days you've heard about neural networks, AI, and so on. These are just black box methods. Model-based methods are those methods that you can look into how the box, which is no longer a black box, becomes a white box. So you can see how this works. So I'm going to apply model-based machine learning on MRI. The aim is to discover subtypes, and in order to validate the subtypes, we look at if different subtypes, they have different courses over time in terms of disease progression. We also, because the data comes from pharma, so we have access to treatments, and MS, unlike Alzheimer's disease, we have some positive trials which we're going to leverage to look at the treatment effects. And finally, we use the same methods to try to stratify and stage patients. So the data comes from 17 trials. By trials, I mean randomized controlled trials and also observational trials. There are 14 randomized controlled trials, most of which come from pharma. In total, we have 8,545 patients, and this is a longitudinal study, so we have more than 33,490 visits, MRI visits. So we also, I'll show you why we need healthy controls. We needed healthy controls to develop norms for the models we're going to use. And for that, we looked at UK Biobank data, MRI data, which at the time there were 13,000 MRI available. I think at the moment there are more than 20,000. And also Human Connectome Project, which we had about 1,100 MRI data. So this is a model-based method that we applied on this data. It's called Subtype and Staging Inference, or SUSTAIN, which we developed at UCL. The idea is that we have short-term data from patients or cross-sectional data from patients, and the idea is to stitch together the data to be able to find a long-term trajectory. Because, for example, over two or 3 years of a lifetime of a trial, you wouldn't expect to see the whole trajectory of the disease. So this is a work done on frontotemporal dementia and Alzheimer's disease. This is a schematic figure. So here, for example, you can assume there are two different subtypes that they follow a different trajectory. So if you look at the sequence of events of abnormality, of MRI abnormality, these different subtypes that I call them subtype, these are groups of or subgroups of patients who follow a certain sequence of events or certain sequence in the abnormality of MRI. So once you stitch together this data, you come up with a trajectory that is unique to that subgroup. And the other thing that we can do using this trajectory modeling, or as I call it, sequence of events modeling, we can stage patients. So that's what I mean by stratifying patients. So if someone comes to you, you can use this method to tell what subtype they are and then how far through the sequence of events they have gone. So it's a stage and subtype. So the paper is published if you are interested in methodological details. So we need a few things here. First, we needed to develop norms, because the model we use, there are Z-score models. We look at each MRI variable and we look at different states, mild, moderate, and severe abnormality. So they go through different Z-scores, 1, 2, and 3. And for that reason, we developed norms on MRI measures that I'll show you in the next slide. So these are the healthy control population we needed. We developed norms. We have separated a priori. We separated our data into a trained cross-validation set of 14 trials or 14 data sets, as you can see here in the middle. These are different data sets from pharma and also from academia. And what we did, we performed a cross-validation here. So we had two questions. First, how many subtypes we have, and second, what is the sequence of events? What's the subtype that we need? So the method we use, I'm sure you're if you work in the machine learning field, you're familiar with the leave one out cross validation. So you leave one MRI or one individual out, and then you try to fit the model and predict the one that is left out. Here, because for several reasons, we decided to put one trial or one data set out, which is a method we call leave one data set out cross validation, and we repeat it 14 times. And we are looking at several things. Again, the number of subtypes, the best sequence that can explain the data, and finally how certain how certain we are about any given subtype, or in the other words, the statistical significance. And I think the most important part is once we have the model, we can subtype patients. We need to validate this model in an external set, which we use the 3 different data sets. CLIMB, which is a data set from Charles Gottman from Boston, BRAVO, which is an RRMS trial, and Oratoria, which was a primary progressive trial. So what measures we had? We had parcellations from brain. So this is a parcellated 3D T1 weighted MRI. We used a method called geodesic information flows, or GIF, as a software, which we have also developed at UCL for the past 10 years or so. It's the work by George Cardoso. We looked at the T2 and FLAIR region loads. We used a DeepMedic software, which is a neural network-based software based on UNet segmentation to calculate the lesion loads across the brain for patients and also for healthy controls. And finally, we looked at the normal appearing. Normal appearing in MS, we divide white matter into lesional white matter and extra-lesional. So when I say normal appearing white matter, it means the white matter that doesn't have lesions. And for that, we looked at a measure that we call T1-T2 ratio, which is known to represent microstructural change in the white matter. Could be myelin or other microstructural change in the white matter. And this is usually missed in MRI studies because I think we focus too much on lesions in MS, and here we try to look at different parts of the brain and different pathologies in MS. So one big question, you end with any MRI and big data analysis, you end up with more variables that you started usually. So we had to select variables to reduce the computational load and also to simplify the models. So for that, we used the trained data set that I showed you to compare healthy controls and patients. So these are the variables. I just quickly go through them. And on the top, there were a few, I think 5-6 variables from gray matter, different lobes, occipital lobe, temporal lobe, and so on. In the middle, there was the lesion load from FLAIR, which is very obvious because patients with MS develop lesions. And finally, there were 4 or 5 different white matter regions that had different T1-T2 ratio. So for that, we used effect size. We used the Cohen's d to select these variables. So this is a fully data-driven way of selecting subtypes. So this is a big question is how many subtypes do we have? So the model is completely blind to clinical subtypes, and this is a Bayesian model. So you start by fitting a model with 1 subtype, with 2 subtypes, 3 subtypes, 4, and so on, and it's an unsupervised clustering method. So the first question was, how can we choose the number that can best explain the data? And for that, what you see on so these are the different colors that represent the data set in the leave one data set out cross validation. So each color represents one trial that has been left out, and we have repeated this 14 times. And we lose log likelihood. So likelihood comes from a model that is called a mixture model in computer science, which we look at how the probability density function of any given value for any patients using the distribution of healthy controls. So basically, we are telling if we have a model how likely this model is when you keep adding subtypes. And what you see here, we are comparing different models with more subtypes. So you add 2, 3, 4 subtypes, and we stop and choose the best number of subtypes once this likelihood stops showing improvements. And the best number we came up was number 3. So once you keep adding 4 subtypes, you don't get increase in your likelihood. So just quickly going through the demographic of patients, we had relapsing remitting MS, most of the patients as expected. These are the most common types you see in clinical practice. Then we had about 1,600 SPMS and more than 2,000 PPMS. We have usually in practice we have less primary progressive MS, but because we looked at clinical trials here, we had more PPMS. Age is as expected. Patients are in their 40s. Most of the patients are women, as you would expect in MS. What you see EDSS here is the expanded disability status scale, which is the disability we use in clinical practice. It goes from 0 to 10, and the higher means patients is worse. And this is duration. Patients with SPMS, they have about 14 years of this duration, and patients with PPMS and RMS are very similar, 3 to 4 years of this duration. So this is probably the most important slide is the subtypes we found. So there are 2 things I want to show you. There are 3 subtypes, so you can't see the separation here, but they represent one subtype. These 3 represent another subtype, which we call normal appearing white matter, and the other one is a lesion first subtype. So we call these subtypes based on how across the brain, how this abnormality progresses over time, how these different patients accumulate abnormality. So the first one, which we call cortex first, and what you see here is the level of abnormality. It's basically a posterior distribution of your model, your Bayesian model, and it goes from mild, moderate, and severe. So you have 3 different Z-scores, right? 1, 2, and 3. And these are different stages. At the very beginning, I told you we're looking at stratified patients. This is what I mean. So if you get an MRI scan, you can say to which of these 3 subtypes a patient may belong and how far through the sequence they belong. So we had 13 variables and 39 stages. I'm showing up to stage 34. So the cortex first subtype is, so the name obviously is a name that we term these subtypes, and we term the first one cortex first because they start from occipital and parietal lobe atrophy. The second one, which we call normal appearing white matter, is the subtype that starts from T1 T2 ratio change in corpus callosum. And the last one is lesion first, is the one that starts from severe accumulation in lesions. And then, as you can see in the middle, I'll show you another slide next, that you see change here in the deep gray matter. So the subtypes, they have basically different trajectories. So basically, this is the same slide, just showing the subtypes in a different way. These are the stages patients go through, 39 stages. You see different colors, again, mild, moderate, and severe abnormality. And so patients, they go through these sequences. So for example, if you find a patient stage 34, they have gone through all these different mild, moderate, and severe abnormalities in their different variables. So let's look how our model was completely blind to the clinical phenotypes. So the first question, how does this relate to the clinical phenotypes we know? So the most common phenotype was the cortex first, about 40% in total. They were cortex first. The second most common was normal appearing white matter first, and the last one is lesion first. And what we see, for example, in patients with secondary progressive MS, with patients who have had MS for at least 14 years, they have more lesion first subtype. And when we look at the age, duration, and disability comparison between these different subtypes, they're actually very similar. And also gender, I'm not showing the gender distribution, that's very similar, they're not different. But just patients with lesion first, they slightly have a higher peak in EDSS disability, but it's about half a point different. It's not significant, clinically significant. So we are looking at the external test set. So what we're doing here, we're looking at a relapsing remitting trial, BRAVO, which was a trial of laculimab. Laculimab is a drug which actually failed, but we used the trial as a natural history trial to see if these 3 different data sets, and this is the data set, and these are the variables we haven't used in the model. So it's a true external validation. What we're looking on the vertical axis is the confirmed 24-week disability progression. Means once a patient progresses according to EDSS, then if they are confirmed after 6 months, we call that an event. And these are survival curves. So patients with lesion first, they have a shorter time to develop EDSS progression compared to normal appearing white matter and also the cortex first subtype. The second data set, this is again the same data set. We're looking at other clinical variables. The first one is relapse rate. So what you would expect from patients who develop lesions, they have more inflammatory phenotypes. And actually that's confirmed by looking at relapse rate. And patients we see here lesion first, the blue one, they have, the error bar represents the standard error. So they have significantly higher relapse rate. And these are patients with cortex first. They have lower, as you would expect, the relapse rate. And the right one is the GAD enhancing. GAD is the contrast enhancing material that we inject to patients, which shows, may represent blood-brain leakage, which shows the acute inflammation. So what we see here, patients again with lesion first, they are the ones who have, this is a Poisson model, so we're looking at the counts, the number of lesions. And patients with lesion first, they have about 3 times, 200%. So this is the percentage of change. So they have 200% more, means 3 times as much lesion, GAD enhancing lesions as the other 2 groups. So we also looked at the third data set. This is Oratorio, which was a primary progressive trial. Again, so we're looking at another measure, which is a 9-hole peg test. 9-hole peg test is a measure of hand function, and we use a 20% threshold to define when an event happens, when patients progress. And again, we see patients who were on lesion first subtype, they have a shorter time to reach disability in hand function.
That's the placebo.
This is, so the Oratorio was a positive trial, unlike Bravo. So so we're just looking at the numbers that are small. We're just looking at the placebo because it was a positive trial. So I'll show you in here that, for example, here we're looking at all the trial to look at the treatment response. So probably I think the most exciting question, is perhaps recruiting patients in a clinical trial. So the idea here, is you have a model, you want to scan patients, you want to recruit patients in a trial, you want to enrich a trial with patients who are more likely to respond, and then at the end you want to save millions of dollars. So this is the take-home message, I think, is that patients on lesion first, there are 3 different trials, all are progressive MS. They respond, they have the greatest treatment response to anti-inflammatory drugs. So what you see on the horizontal axis is not very clear. What I can explain is the percentage change in the slope of EDSS change. So we're looking at how fast EDSS worsens over time. And EDSS higher means worse. So you want to reduce the slope. So you want to slow down the progression. We can't stop it, but we can slow it down. And what happens is patients on lesion first, they have the greatest response. But I think there's something more interesting to me was that if you look, this is no response. It means the patients here, they don't benefit from the treatment. And there are many, and these drugs are really potent drugs. They're difficult to administer, and there are many patients who do not benefit from the treatment. So it's good to look at who actually responds, but also who does not respond, because you don't want to expose patients who may not respond to a treatment unnecessarily to a treatment. So this is another way looking at this. So we are looking at 3 different trials together, but if you look at individual trials, you get similar answers. We couldn't look at individual ones because of agreements with pharma. Anyway, so I'm getting to the end. This is the staging. So if you remember, going back to my model, we looked at subtypes, but I can also tell you an MRI, a given MRI is how far it is through the sequence of events in a given subtype. So they can go from 1. So we have 3 tertiles. We divided 39 stages into 3 different tertiles. So these are the numbers, 2,640, and you don't see another one that's pink, and 2,641. So the 3 groups. And the message of the slide is patients who have progressed more in their trajectory, they also have faster time to progress, faster time to reach disability milestones. And you see that 7 to 39 is the stage we give to any MRI based on the model. Just this is my last slide to summarize. So I showed you we used data-driven subtyping, and we found there were 3 subtypes. They responded differently to treatments. They had different progression rates according to different progression metrics. And finally, we are actually working on this. So far we have been looking at, for example, anti-inflammatory drugs. We hope to look at repair drugs or putative repair drugs, for example, for remyelination. And we want to also expand it to other populations, such as pediatric MS here. At the end, I would like to thank many people. So these are just a few of them. Alan Thompson, who is my mentor at UCL, Doug Arnold, who has been here, Declan Chart, Danny Alexander, who is at UCL, Frederick Barkov, Olga Ciccarelli, Sirdar, who has been helping a lot with Doug, people who have helped us in data organization, Rosie at McGill, and the whole project is funded by Progressive MS Alliance. And thank you for your attention. Yes, so we had a slide on. So do you mean? So let me get to the GAD enhancing slide. This one on the right is GAD enhancing lesions. So the ones. So it's not part of the model. So we don't need.
My question was, did you try to add it in the model to predict the response to the drugs in pharmacy patients?
No, we didn't do that because. So there are a few problems. First, I don't think GAD enhancing lesion is the best quantitative measure. Second, you need a normative sample from healthy volunteers. Healthy volunteers, they don't need GAD enhancing lesions.
But they don't have T2 lesions?
No, they do. So we do. So you develop T2 lesions over time, even if you are healthy. So there is aging. So they're vascular. So I mean, even if you look at the UK Biobank, there is significant change. But GAD enhancing lesion is not routinely done, and actually even for MS, for many MS trials, we didn't have GAD enhancing lesion. So it's not part of the model, but we used it to validate the model. The other problem is if you use the GAD enhancing lesion in your model, you can't use it to validate the model, right? Because it's become circular.
Yes, okay. I understand, but probably it's something quite interesting if you want to predict the response to drugs, especially in progressive MS patients. But yes, I understand your point of view.
Yeah, thank you.
If you don't mind, maybe repeat the questions before you answer them, because we're doing a recording and I don't believe the microphone is going to pick up necessarily.
Yeah, sure.
So, a quick question, maybe not that quick actually. Do you have hypotheses on the mechanisms of like why the drug is working for the lesion first subtype and not for the cortex first? Do you think that those drugs were actually designed with the lesion in mind? Like, I don't know anything about the basis for those drugs. Could you comment a little bit on?
Yes, sure. So the question is there any pathological mechanism or any underlying mechanism that can explain the different behavior of lesion subtypes? So this, the drugs, they haven't been designed for lesion first because, as we mentioned, they might have been designed, for example, with GAD enhancing lesions in mind, but not this sort of modeling. But patients who so these are anti-inflammatory drugs. They have very different mechanisms, but at the end they converge. All of them, they converge to modulate or suppress immune system. So whatever you think that can, any patient who may have a profile that has an active immune system, obviously they are going to help those patients. And based on these results, my hypothesis is that lesion-first subtypes, they have a more inflammatory phenotype, and that's why they respond better. So this is a fact that was known before this study. It's not that we're showing it, but it's been very difficult to to choose patients who are inflammatory. So how is there a biomarker we can use? No, there was no biomarker. Maybe you could use a relapse rate, younger patients, GAD-enhancing lesions, and so on. But what we do here differently, you can actually separate patients and those who do not respond. So this is the hypothesis that I generated from this.
Your slide right there confirms that the lesion first subtype is having more inflammatory profile with lesion counts and high relapse rates.
Exactly, and this is exactly. But I think the other message here is that this is irrespective of clinical phenotypes. In a way, it's saying, look, these clinical phenotypes. So this cuts across clinical phenotypes. So that's what we're trying to say, that doesn't matter what clinical phenotype you have, you can separate patients and then try to tackle specific mechanism.
So, but I'm guessing you did look at clinical phenotypes, for example, in the lesion first. Is there like a tendency for certain phenotypes to be present at the lesion first? I'm just trying to figure out how, like, we're looking at bottom-up and top-down approaches, and how, if we even expect them to relate to a certain extent, because we have the same problem in Alzheimer's. So
Yeah.
just wondering.
There's no one-to-one correspondence, and I'm showing it. Maybe it's easier. So this is the correspondence between data-driven phenotypes and clinical phenotypes. So you can't correspond clinical phenotypes with the MRI phenotypes, but there are a few features that may help. For example, lesion-first subtype, they are more common in secondary progressive MS, and secondary progressive MS patients who progress, who become secondary progressive MS because they no longer relapse and remitting MS, so they start to progress. And lesion-first, when you look at how they progress over time, is they progress faster. So in a way, I'm just saying that it doesn't mean this is a reason, or there's no cause and effect arrow that you can, this is causing, for example, being SPMS helps you to be lesion first. So I think they are independent. But looking at disability, you can somehow find that lesion first is more represented in secondary progressive MS, and so on. But the answer to the question is no. I don't see any clear.
So for some of us who don't know multiple sclerosis, by the time it goes from relapsing remitting to secondary progressive, are we looking more at a neurodegenerative change versus just an inflammatory change?
Yeah, in a way, yes. Yeah. Although the inflammation is more obvious at the very beginning, but it's believed to become in a way trapped or undetectable during the progression. And it's difficult to say if neurodegeneration becomes worse, but it certainly accumulates. So over the patients with SPMS, they have, as I showed you in a slide, they have 14 years of disease, whereas RMS, they have 4 or 5 years. So obviously they accumulate everything. Yeah.
So maybe more technical questions. Something that's really impressive about your work is your sample size, but also the fact that you have so many studies. So it's really you actually test generalization. But did you test for association between your subtypes and actual studies that were generated from? Because there are potential biases in the measurements you're making. So did you investigate that?
Yeah. So the few things. So first, we try to use the studies that are more recent. So MRI, of course, it changes and so on. So we have in the MRI they use the same they don't use the same protocol, but they have the same modalities and so on. But we did actually one thing. There are 2 problems we had. We were looking at the center or study effects, and here we had these are RCTs, and RCT, if you look, they have strict recruitment criteria. So the trouble was we weren't sure how you can actually address because you have effect of interest, because they recruit patients with very widely different criteria, but also MRI changes and study changes. this is a very difficult, important but very difficult problem to address. So what we didn't address that explicitly in the model, because if we're doing so would completely regress out or completely cancel out your effects of interest. But what we did, each time of this cross-validation, you generate a different trajectory, right? And what we did, we looked at how the level of agreement between different trajectories from different folds of cross-validation. So you have 3 subtypes and you have 14 data sets. So you end up with 14 multiply 3. So it's like 42 trajectories, right? So for different subtypes. And we looked at the level of agreement. So, if you start from cortex first, and do you go through the same subtype if it was a different data set? And actually the answer was yes. So we use a method, it's called Bhattacharya distance. It's something like, it's not correlation, but you can think of it as a correlation. So it goes from 0 to 1. 1 means perfect agreement, and it looks at how the level of overlap between different distributions. And the overlap was more than 95%. So while of course there is MRI protocol effect, there is study effect, they have also been acquired over the past, 15 years, so there's also time effect. But the trajectories, they were not affected that much. And at the end, to be able to address that problem, you need to make sure your model, whatever that model is, can be first, it was reproduced, but can be generalized into a new data set. Even if you look at completely new data set, you would like it to work. So I would say the fact that it has worked in the external set, that's an evidence that.
Absolutely. So you have empirical evidence that it is robust.
Yeah.
So you didn't have necessarily to bother correcting for it. Because as you said, it overlaps with biology.
Yeah, we were aware. We didn't correct it for that. We didn't correct for that. Yeah, as I said, for very good reasons. Yeah.
Like we have this exact problem in fMRI. We do have side effects and they do drive the subtype, and we don't know how to really correct for them for the exact reasons. So a bit stuck. Yeah, we didn't explicitly adjust for that at all. Yeah, and also different MS subtypes. So this is the other thing. Different RCTs, they recruit, one of them recruits RMS, the other one recruits PPMS. So how can you adjust? I don't know, because... ANI does that too. There are many sites, but some sites contribute mostly patients, so they're mostly controlled, like they're very imbalanced, because I assume all their sites are comparable, which is actually fairly true in structural imaging and not true in fMRI.
Yeah. Well, also not true in structural MRI, for sure.
It's just an amplitude problem. In structural MRI, it's much more subtle than the fMRI is like very large bias in some instances.
Yeah, and the other thing is if using simple models, regression models, you can quantify the effect of center versus the effect of interest. So if you're interested in subtypes, and not for this study, but I've in Magnims, which is a European network, we looked at this to see if, for example, looking at thalamic volume. Is it more responsive to the center change or to change in disease, for example, going from one subtype to the other? Actually, what I found was my PhD project was that smaller structures are less susceptible. So, for example, thalamus is less susceptible to center effects, and more. It doesn't mean it's not susceptible. Less susceptible to center effects compared to the disease effects. But if you go at the level of the whole brain, it's not true. So it's an open question. Yeah.
A very different question now. So you have 3 subtypes, and I don't know if you have familial cases in there, or if you would even know. But has anybody looked at the subtype level of if the father has this, the child also has a similar subtype?
Yeah. So the question is, I think somehow the relationship and the kinship and also the genetics behind, if I'm correct, behind the subtypes, how they subtypes relate to relationships. So we haven't looked at that, and actually we didn't have the data for several reasons. The data was double de-identified and anonymized and so on. I can't comment. But we're looking at ways, actually with dog, to see if they relate somehow with genetic signature and so on. but it's something I don't know. Yeah.
There may be some trials like the gene MSA that we have.
Yeah.
Well, we don't have it yet, but there exists the genotype data.
Yeah. So yeah, there are about I think so far 200 genes in MS that are known to affect the disease somehow. So yeah, that's.
So, you couldn't test necessarily the sort of heritability because you need people with MS, several generations of them with MRI, so it's not happening. But yeah, you could, if you have the genetic this sort of information, you can test if the similarity of genes predict the similarity of subtypes. So it's more like
yeah, that's a very fascinating question and something we would love to work on. And yeah, some trials actually they do have the GWA. Yeah.
If we use some major genes that should.
Yeah, exactly. I think that would be extremely helpful. And at this sample size, I think we can get something useful, really.
so I don't know if are you going to be there this afternoon?
Yeah, well, yes, I don't. Yeah.
So you should try to catch at least Clara or Sebastian because I do subtyping in autism and neurodevelopmental problem. One does it like gene first approach, the other one like brain first approach.
Oh, okay.
And yeah.
Yeah, sure. That would be very helpful.
So when you presented this to us, you had more slides, and I think one of them was showing that your subtypes were more predictive of subsequent disease progression than clinical subtypes. Am I remember?
Yes, true. So we looked at the effect. If you have a certain clinical phenotype, how likely you are to develop disease progression versus these subtypes, and then it turns out that actually using imaging driven subtypes is more predictive than MS clinical phenotypes. Yeah.
Clinical progression.
Yeah, of clinical
So are certain subtypes more?
Lesion first. Yeah, lesion first, for example, is the one that progresses the fastest. Yeah.
Yeah. So the fact that it doesn't line up, it doesn't recapitulate the clinical phenotypes, the clinical types, it's an advantage. It shows that it's giving you some extra information. It's probably more closer to the actual disease pathology in the brain than the clinical phenotype.
Yeah, for sure. Yeah.
Also, like a really naive question, but maybe not so naive. Why 3 subtypes?
Yeah, so that's a very good question. We actually spent a lot of time, on choosing a number. So it's a Bayesian model. If you do Bayesian modeling, you have a step that is model selection. So we perform model selection here, and that was based on log likelihood. So here, this is the model selection we did. So you want to minimize. You want to get the model that can best explain your data. Okay, so the model given your data is basically posterior probability. So, but what we used here is the model evidence, or if you do fMRI, I think in DCM, for example, dynamic causal. So at the end you look at the model evidence. So you want to have a model that is most likely given the data, and that comes from the likelihood function. That is something we can think of it as a black box, but I'm happy to go through the details. So you have a function as likelihood function, and what you want to maximize that. Okay, and at some point you stop. So if 3 versus 4, you increase the likelihood, but once you go to 4, you stop increasing the likelihood. And yeah, you can, this is an unsupervised method, right? So you can ask for 10 subtypes, and it will give it to you. You get 10 subtypes, but at some point it becomes it doesn't improve the prediction, and yeah. So 3 was the magic number. Yeah.
It's always complicated to choose the numbers, and there was a big talk at SBM years ago where education came out and Steve Smith went to the microphone, and the question was like, why 7 subtypes? And the answer is because it's a cool number. I think there's a lot of wisdom actually in that answer.
Yeah,
I feel like I've wasted my youth trying to find the right number, and I'm not sure it's a very fruitful question.
Yeah, I fully agree. So I completely agree. So this is an open question. But what you want to do is to use an objective criteria, so you don't cherry pick or hand pick somehow. Even sometimes there's cognitive bias also with everything we do. So this is it's an objective way of choosing.
I think it's good to have an objective way, but I think good analogy is quantization in images. So you can reduce the size of an image by replacing colors that are similar by a single color, and you can have a good approximation of like La Joconde with 5 colors.
Yeah.
And you could say there's 5 colors in La Joconde, but there's not 5 colors in La Joconde.
Yeah.
If you want all the details, you need millions of colors. So it depends on how much details you want.
Exactly.
And
Yeah.
that's also going to depend on how much data you have.
Exactly. So if you add more modalities, genetics and DTI and whatever, you will keep finding new subtypes, right? Yeah.
So I'd like you to maybe comment a little bit more on the prediction stuff, because I think, you made this great point that the cortex first did not respond, and maybe we're exposing patients to side effects for nothing. Is that really just on average, or is everybody in that group just not responding?
No. So this is standard error. So it means the confidence interval is going to be somewhere here.
Okay.
This means there are, I would say, more than 70% of patients with cortex they don't benefit from treatments.
Yeah, but will you be confident to tell people don't take the drug if you know that 30% of them may actually benefit the drug?
Well, that's I think you need a proper risk-benefit analysis.
Yeah.
And I'm not saying we shouldn't, but this is something to think of, something. But yeah.
I don't know if Anad could maybe quickly show that to you, but we've got this idea. We worked in the lab about high confidence modeling, where you basically try to say the people for which you will have no improvement.
Yeah.
So try basically to have some kind of confidence interval on your prediction and narrow it down so that, when you say people won't progress, it's actually almost certain they won't progress. It's a very simple idea. It's playing with confidence interval that are built in most of those models, but it actually works in practice fairly well.
Yeah, I think that's a very interesting point, because you just also don't want to rely on p-values, because also you look at p-values, just as I said, you can say all patients with cortex they don't respond, which is not true. As you said, there are individuals who may benefit, and that's not
so that
easy.
work is really with proper cross-validation and trying to maximize the positive predictive value or the negative predictive value. Basically.
Yeah, exactly.
And I think negative predictive value is potentially even more valuable than positive predictive value. You really don't want to give a drug when you know it's not going to work.
Yeah, true. Yeah.
Also, how do you deal with, I guess it's partly related to Pierre's question, but not directly. How do you deal with the people at the extremes, or at the edges of a subtype where they might be this subtype or that subtype?
So the question is, how do you deal with the uncertainty with subtyping, which is an excellent question. So this is a probabilistic model, so you get probability of belonging to each subtype. So there's not even one patient here who belongs to one subtype 100%. So this just doesn't happen. But this is what I've done, for ease of communication, but just to be clear, we thresholded patients. So any patient who has more than 33% of the 3 subtypes, more than 33% chance of belonging to a subtype is in one subtype. But we did a lot of work on that one. So this was a longitudinal study. So we looked at the visits, follow-up visits. This can be done cross-sectionally. We also looked at the follow-up visits independently from the baseline. And without putting any threshold, you see that 75% of patients, they don't swap subtypes, so they don't switch subtypes over time. But you also have the ability to threshold. So if you increase the threshold, so you become more strict in choosing subtypes. And I used 90 or 95% threshold. So you say if the model tells me this patient is 90% this subtype, then I'm going to choose them to be in this subtype. And then you see that in that scenario, more than 95% of patients, they stay in the same subtype. But that means you're going to exclude, let's say you're running a new trial, so the model cannot tell you what this patient may belong to this subtype or that subtype and so on. So this comes at the cost of excluding more patients. And I would say I think, if you increase the threshold to 90%, you lose about 20% of patients or so. So when you want to select patients, again, that's something. But so what I'm trying to say is, it's not deterministic.
maybe that's a price we should be paying, you know, like maybe we just don't have this information, the particular data you chose to include in your subtyping procedure. So you study that you would be able to subtype everybody and it would be predictive for everybody, like maybe that's something
Yeah, true, Tommy. We have been not had part of this project. We are applying this to new data sets, and I have patients who, you know, they belong to the subtype 50%. So I don't feel comfortable. Just 50, I would like to have something at least 75%. So yeah.
And those thresholds can be question specific. You're trying to decide whether to dose someone with one of these therapies, then you would be more. You would have a higher threshold. Like, how sure are you that the lesion first subtype? And then if you do that, you might find that you're.
Yeah, exactly. We have doing that actually on another trial with doc, and so and this comes at a price because the patients, they need to go through MRI, and it's not free. I don't know if it's free here. It's not. And then suddenly you scan 500 patients and you just need 200 of them, so 300 people. So the other problem is, how can you tell a patient? It's a model, right? Yeah, the model told us you're not eligible to be into this trial. I mean, I don't know how we can tell this to a patient.
You need the validation.
Yeah, well, anyway, I think there are many challenges. It's not, but yeah, I agree.
But at what point, because IPMSA is like a drug company, industry, academia kind of adventure. So clearly there's great interest in translating these findings to clinical trials or drug development. At what point would results like this be translatable, or how? Like, have you shown these data to drug companies? What's the response you've gotten? What kind of additional trials are going to be needed?
This is going on YouTube, so I can't tell you everything.
Okay.
But yes, so we are actually working on this in neurotics, and there is interest, and we would want to do it prospectively, and this is possible. It needs a bit of development, but I can tell you this is going to happen the next 6 months, 1 year. Yes.
Can you come back to the plot, the different stages?
This one.
No.
I think this one. Yeah.
So I guess just for people to have more intuition of what these subtypes mean, you kind of explain what the differences are between the subtypes in terms of when you accumulate a certain amount of abnormality on the different vendors.
Yeah. So what we see here, we are looking at, there are 3 colors. You can think of 3 colors: mild, moderate, and severe. But you can think of it as standard deviation. So how far a color is from the peak of the distribution of healthy controls, okay? Adjusted for age, total intracranial volume, and so on. So we have 13 variables. They were chosen from MRI, and then you end up with 39 stages. So each subtype has 39 stages. So if, for example, if I'm these patients from this subtype, they start from the cortex first. They start from here, these 2. They start from mild abnormality of mild atrophy in the cortex, and they go on stage 3. They have atrophy in frontal gray matter, and so on. For example, stage 16 in this patient, they develop mild abnormality in parietal white matter T1, T2 ratio. So patients, they go through this trajectory for each subtype, and basically you can think of it as an event position. So if you are familiar with the models called event-based models, so it's in a way it's a crude way of trying to explain the change in your MRI, because we know that MRI is noisy and so on. So we try to condense all these continuous variables into 3 states, right? And basically what we're trying to say here is the differences between different subtypes. So this subtype, for example, they have early accumulation of abnormality in T1, T2 ratio, and this is the trajectory. So you can, for example, say, let's say this one, for example, this is easier actually, because patients with lesion first, they develop mild abnormality stage 1, moderate lesion accumulation stage 2, and actually severe accumulation stage 3, and then they go on. So this is a I don't know if you're familiar with empirical based. This is empirical based. So this is a posterior distribution of your model at the group level. So this is basically the three models. The probability of the three models that can best explain your data are these three. Okay, and it doesn't mean, for example, if you're lesion first, you're exactly going through this trajectory. It doesn't mean that, because you can never belong to one subtype. And this is the other thing, so that when you subtype a patient, you get different stages per trajectory, because they belong to this 70%, they belong to this 20%, and they belong to this 10%. So you end up with 3 different stages, right? But the way we do it, we weight subtype by stage, and then we come up with the final stage. So this is how this is empirical based. So you have posterior distribution at the group level, and then you go at the individual level, and then you can, using the likelihood function, which we can discuss, you get the stage. So this is it's basically a condensed way of explaining everything in one slide. Yeah, was it clear?
So it's new. We can continue discussing, or I know people have to go as well. So, but people want to discuss, please stay behind. And
Yeah, I would be very happy, and actually I'm very interested in
I wanted to
the work you do.
Thank
Thank you.